effort to study all these tens of thousands of genomes we're working on. So in summary, there's lots of different genes involved in autism spectrum disorder, and I argue that it's a complex human condition that will best be understood using big data approaches. Many of the genes we found are involved in other neurodevelopmental disorders, and this is the hallmark of medicine, actually. Medicine, a disease follows a clinical history. It's defined based on the knowledge at the time, and what we're finding now using genetic approaches that in some cases has helped redefine what that disease definition is. I think at the end of the day, you're always going to have the clinical investigation, and we think the genomic investigation. It's really just which one happens first. And now that we can sequence a genome for $1,000, you can do one of these microarrays for actually $30 for some things. You're going to do them first because I can process all those samples. There's 500 kids who are on wait list to get to see a neurodevelopmental pediatrician in Toronto. They have a suspected diagnosis of autism. We can run those 500 kids in less than a week, and at least for 20%, and I can tell you which ones need to be prioritized. It's a matter now of getting the systems in place to make that happen. And then last, I think for the students, as you're thinking about going forward, you need to design every experiment you're doing in the context of big data and the genome, if it's with respect to a genetic disorder in particular, because you're testing one hypothesis, say a gene at a time, you're only going to be as good as the data that you're generating on that gene. You need to see things kind of in an evolutionary perspective by looking at the entire genome. That sets up the next talk because you have to have a strong standing statistics to do this. That's it. Thank you.
Question or two for Steve. Go ahead, Peter.
You talked about big data perhaps being the best way of understanding this phenomenon, this complex phenomenon. And I guess one issue that's emerging is the difference between understanding and informing. Like there's recent suggestions that a spike of IL-17 might affect neuronal development, and that might then affect critical periods where synapses have to be turning over, so that your resilience that you're talking about could have been sort of determined 60 years ago. And the question is, how do we go beyond precision, which is just replication? And your recent result shows that you can't replicate the prediction of the gene predicting that autism will be developed. How do we go beyond that concept of precision, replication, or repeatability, I guess, to having a wider, more I guess, subtle view of what we're doing, how this big data is informing rather than leading to understanding?
Yeah, it depends on the context of your question. So medicine itself is very imprecise. You just need to, it's like pumping up a flat tire. You need to get it to a certain level to work. If you're thinking about trying to understand the underlying biological...
I'm drugging a child for life in order to prevent autism from progression.
I could have gave you 100 different examples. It depends on the individual. And the fundamental understanding you need to compare everything to is this linear genetic blueprint. But the way the technology is going now from, I guess, more basic investigations is to look more at the single cell or the sub-regional sections of the brain. We can now sequence entire genomes or transcriptomes in a single cell using these technologies. So that's going to provide some insight. I think I didn't give you some of the data that we've just submitted also. One of the new areas that's come is the issue of somatic mutations that we see in cancer, in such a significant role in cancer. We are also seeing neurological disorders in autism. In fact, we've identified some of these somatic mutations that are leading to more severe phenotype in families, for example, that have Asperger's and an autistic kid. And to the same extent, you can imagine that a somatic mutation may actually lead to a positive modifier, right, just by a random chance. So essentially, you're just trying to get as much information you can to come up with an explanation. But your point is well taken. I think that the challenge is, of course, if you're making these decisions in a prenatal or in a carrier screening, what we cannot say now is where, even with these my top 6 mutations, where on the spectrum or in this neuropsychiatric realm that child would end up.
So I think I better hold any further questions, because I know we're a little bit behind, but please join me in thanking you. So the final keynote speaker for our program is Professor Nancy Reed, University Professor of Statistical Sciences, and also CRC Chair in Statistics. And the title of her talk is Big Data and Statistical Science. So welcome, Nancy.
Okay, well, fascinating talks this morning already, and I feel it's hard to be the skeptic in the crowd, but that's my role, I guess. I'll give more background in a minute, but everything I know about big data I learned about a year ago, because we ran a 6-month program at the Fields Institute for Mathematical Sciences on big data. And most of the speakers who were invited started their talk with a definition of big data. And they often overlapped, but sometimes didn't. I think maybe what we think about, certainly when Arvind was speaking, this is what I thought about. It means big machines. It means lots and lots of computing. It means very complex architecture. And really that's, I think, the domain of computer science by and large. So why am I here? Well, I think statisticians are very good with small data. And what does that mean to students? Well, I think it means a lot of equations, something called mathematical modeling, which is kind of complicated, a little bit of computing. And I think in some sense that's the statistical science has kind of, in a way, suffered from this reputation for quite a long time. Just to look at it a slightly different way, and I deliberately chose an example not from medicine, but this is the Atlas detector at CERN. Big data somehow seems really interesting, very, very detailed, very highly informative, and really an awful lot of fun. Just having a ball because they've got so much data. And I think we got that spirit from Stephen's talk, right? That there's just so much going on and so many new things to discover. And small data is just kind of so yesterday. Well, the program that I mentioned was trying to see how we could kind of get over that. What kinds of things in statistical inference and learning and modeling are important for big data. And it was kind of hard to think about how to structure this because it is a big topic and you could go in so many different directions. We focused on statistical inference in some ways as self-preservation. We kind of want to get statistics in the limelight in terms of reminding people that it's important, but also as a learning experience for us. We need to really see where we can help and where we need more in order to be able to help. So it was kind of intended to bridge the gap between statistics, mathematics, and computation, and science and health, of course. Science and health writ large, and I could have added social science as well. And I found 2 great pictures on the internet. All my pictures, of course, are from via Google, which is kind of a reflection again of what we're talking about today. But the little picture on the right, that's the Bridging the Gap picture. But I discovered a very, very interesting Italian data visualizer who works at the NYU in the data science program, has some spectacular visualizations on his website. But I chose a different picture because it reminds us a little bit of networks in the brain and what Arvind referred to as like new types of data. So this is a description of, in the middle, you can't read it, but it says who is a health data scientist. And then there's various different branches trained in conclusions, and so some things have to do with, not quite trusting your conclusions until you check them carefully. Some things have to do with what you learned at school, and some things, this branch says, go away if you're not well trained, if you're not open-minded, and so on. So it's kind of, I think, captures what we're all struggling with. There's this idea that there's stuff at the core, and then there's all this stuff out there, and it can quickly become a little bit overwhelming. We can't all learn everything, and it all has to feed back to the core at some point. And so I think we made a little bit of a stab at that with the program last year. The way we structured it was we had one set of what we call cross-cutting themes: machine learning, optimization, inference, and visualization. So machine learning, the domain of computer science / statistics, then we heard reference to the deep learning work that Brendan Frey is working on with Stephen, and he spoke at our workshop today. Optimization and inference are really kind of mathy. That's kind of where statisticians like to spend a lot of time. Visualization I have a few slides about later. That's the most fun. And we've already seen some spectacular visualizations, but you notice that in order to visualize the data, you have to actually make it very small. Like Brendan said, oh, I have millions of this and billions of that. I lost track, actually. But his plot had about 30 or 40 points on it, because that's all we can look at at one time. So there's a real art to doing that, and the science. And we had another set of areas that we called cross-cutting. These were the four that we emphasized in our program: health policy, social policy, environmental science, and network science. Oh, we could have had dozens more. We could have had genomics, we could have had finance, we could have had, you can name them. Yes. Oh, I'm sorry, yes, thank you. We could have, all the areas where data is needed. We had to stop somewhere. And again, we were trying to emphasize the core areas, the top 4 areas that we focused on, branching out into the 4 areas that we discussed during the program. So I'm going to spend the next slides just showing a little bit about visualization, health policy, and social policy. And I'm going to start with health policy. So it's not personalized medicine, it's at the more step back a level. And there's many very interesting things related to health policy and big data. But one thing that I learned about that I thought was quite interesting was something called pragmatic clinical trials. You may have read about them in Science. Kind of an alternative to the randomized clinical trial, and one of many new ways to assess health interventions. And here's just one example. So if I had a very conventional, boring statistics picture, it would show a bunch of people, presumably people, or hospitals or schools or clinics, getting X, and the others getting O. One's getting the new treatment, one's getting the old treatment. In this setting, eventually, all the hospitals will be converted over to the new treatment, but in this kind of step wedge design. And that will work over time. It's much easier to get people to enroll in the step wedge design because they know that eventually they'll get the treatment. And at the same time, you can randomize the order in which clinics enter and get some of the information you get from the RCT. So that's just one way in which health policy or biostatistics researchers are trying to move along the development of statistical methods so that we can be a little bit more creative and not rely on traditional randomized controlled trials. They will still be needed, and there was mention to this large A/B testing that can kind of happen automatically. That's fine for simple things, but it's not so fine for complicated diseases and disease treatments. The other really important theme in health policy is linking health with other databases. And of course, we're very fortunate in Ontario to have an incredibly rich database up at Sunnybrook called ISIS, the Institute for Clinical and Evaluative Sciences. They have access to the whole OHIP database. And the person who spoke from ISIS was sort of, I felt kind of uncomfortable because she said, I know everything about all of you. If you've been to any of our Toronto hospitals. I said, okay. So I mean, she's a friend, so I don't want her to know all my health information. Of course, it's been anonymized, so this is rather small, but I wanted to remind myself of the pieces. They have individual level health data, that's the first point. It's linkable. So there's information there about continuity of care. If you change doctors or you move to a new town, they can follow you. It's longitudinal. They've been collecting this data since my oldest daughter was born. And it's population-based. It includes all publicly funded health services, so not just your GP, but if you go in for special testing or genetic testing, or if you've gone to a physiotherapist, that's all included. This is the part that caught my ear when she was talking about it. De-identified, security and privacy protected. That's important, right? That's extremely important. And they've gone to great lengths to protect it. But that was a huge part of many of the talks that we heard on both health policy and on social policy. Privacy is really coming to be a big issue. Arvind alluded to this, and there were 2 publications that came out in maybe the last 6 or 8 months in Science and in a statistical journal called Significance on the science is rather aggressively called the end of privacy. This is, I think, an area that if I were young and starting out, I would like to spend a lot of time on this. This is fascinating. There's many different approaches to privacy, and the most common is anonymization. And that's what ISIS uses. They take away they know your OHIP number, but they give your file a unique identifier that only they know. And then if they release the data to researchers, that your OHIP number doesn't go with you. The Privacy Commissioner of Ontario published a paper in 2014 called Big Data and Innovation, setting the record straight. De-identification does work. Well, you can sense that she's reacting to something else. That was a series of papers saying, breaking de-identified records. Within a week, 2 computer scientists have published more blog. It still doesn't work. This is a debate that's not resolved as far as I can tell. Many people are working on it, but I don't see convergence of ideas. That's one approach to privacy. The approach that Statistics Canada has followed for generations is a little bit different. It's called statistical disclosure limitation. And it's basically a small data technique. They run a lot of different checks on the tables they plan to release to make sure that you can't identify, to make sure to the best of their ability, and you can't identify any single individual from those tables. And you can quickly see how, as the tables get sliced and diced, that becomes really easy. Like for years, I was the only woman full professor in my department, so any anonymous survey that asks for my gender and my salary and my department is no longer anonymous, right? My salary is not anonymous anyway, it doesn't matter, but you can see where it's going. It's very easy to identify someone with enough data or even metadata. But Statistics Canada is very proud that to their knowledge, they've never had a breach, nor has the group at Sunnybrook, to their knowledge, ever had a breach, because it's really hard to get your hands on their data. You'll know, there's many, many, many checks and balances, and most researchers would probably, unless they were really impassioned, they might give up before they got to that stage. But Jarvind also mentioned, I mean, we don't want all this data sitting around locked up. Right? There's other approaches to privacy being developed by computer scientists. Multi-party communication is a kind of way of exchanging keys that you might be somewhat familiar with. It's used in financial transactions all the time. And then there's an emerging notion of differential privacy, which as far as I can tell is a relatively theoretical construct that people who develop the theory believe in very strongly, but the people who want to use the data say, at this rate, we'll never get any data. It's, roughly speaking, you contaminate the data so that the statistics stay the same, but the individual data records aren't identifiable. And if you can, it's hard to do, because if you have to contaminate it so much that the statistics just can't stay the same, is what the critics will tell you. So that's the health and social policy areas. And just a warning, since I'm the skeptic in the room, remember Google flu, they badly overestimated the prevalence of influenza by using no statistics at all, but just a big hunt for keywords that looked for things like, well, people searching with words that related to the flu. So in the end, what they were detecting was partly flu and partly winter, basically. And they were overestimating the influenza epidemic size by 50%. That's large. That's a big mistake. They don't publish Google flu trends anymore. It's not working very well. So there are these warnings, and there's, I could have come with many more, but I don't want to seem overly skeptical, but it is something to remember. This Grand Rounds is about personalized medicine, and I have very little expert knowledge about, but of course lots of personal interest in. But it does relate to some topics that statisticians and philosophers of science have been thinking about for many, many, many years. How would a precision treatment be assessed? How would you assess causality? How do conclusions from these studies apply to you? You don't really want to be in an experiment of one. You want to take a drug that's been shown to work for you because a lot of other people just like you took the drug and got better. So we need a lot of other people just like you, so that somehow there's some, I guess the point of the big data is we'll find more people just like you, but there won't be very many. So it's still going to be a small data problem. And assessing causality in small data is very, very difficult. In big data, no simpler, I'm sure. But I did come across a really nice article in the New York Times about a big program at Mount Sinai in data science, and I understand that we have programs here at the University of Toronto as well. And this is just super important for statisticians, for computer scientists, for data scientists and mathematicians and medical colleagues to work together. And I hope we can break down these silos as much as possible to do that. When would you like me to stop? Or I should ask the others. I have a few more slides.
Yeah, that'd be great.
So I come back to the overview. I was just going to say it.
We're not bored yet.
Thank you. That's always good to know. It doesn't happen to me very often. I'll say a few words about visualization, because this was another fascinating area where there's these silos of groups. You would think that they would really be all talking to each other, but they're really not. There's a big group of people in statistical graphics doing very nice work with interactive graphics and easy-to-use graphics. And the best website I could recommend for that is called Flowing Data. And this is, I won't take the time to go to this website now, but this is an interactive graph. And it's why people visit the emergency room, and you can go up and down the graph and see what how the visits change over the course of the year. You can see here there's an increase in the summer, and that's, I believe it's because it's related to some accidents in sporting and so on, but I'm not sure. But this is so this is kind of small data, right? It's not that you can see it, but it's presented in such an original way that you can learn a lot in a very short time, and you can have a lot of fun as well. There's another discipline separate from statistical graphics, which I think is called information visualization, and this is a little more computer sciencey than statistics. And my favorite website for information visualization is the website in Calgary of Sheila Carpendale. This is also interactive on her webpage and too small for you to see, but it's called an edge map. And all the little circles are musical groups and the lines from going from one group to another are influences. And right at the center are the Beatles. And here's the Isley Brothers who influenced the Beatles, and then we have some more modern groups who have been influenced by the Beatles. And this is interactive. You can watch it in time, you can stretch it out, you can fool around with it, you can go in and out. Sheila started life as an artist, and she brings a very artistic sensibility to this, but no statistical sensibility to it, I would have to say. Which of these edges are important? Never mind statistically significant, we can forget that, but which edges are important and how much data is in there and where did that data come from and is it any good? So that's the statistical graphics people should be talking with Sheila and her team and others like her, right? And then there's another kind of group that is also separate and have their own separate meetings, it's scientific visualization. These are sort of the pictures that you might see in science often, and they make complicated things look less complicated in some way, but help you to understand what's going on. And this particular visualization is a scientific map from Katie Borner's group in Indiana. So those are 3 websites I recommend very highly. And if I had a career that was not going to be studying privacy, I think my favorite would probably be to move into visualization. Oh, I forgot the best one of all, the duty of beauty. This comes from journalism. So we had some journalists at the meeting as well. And you can see now on the newspapers' websites, fantastic visualizations of all kinds of different things. They're very creative teams working there. This journalist that spoke about this said, it's not just enough to portray the data, and it's not just enough to wonder where the data came from, and so on. It should be somehow pleasing to look at. And so I highly recommend Front Row Fashion Week, which is also an interactive video that shows you all the designers' palettes and so on all in one. So you can waste lots of time this afternoon on various websites. So that's just a very quick snapshot. The other very, very important and rather new thing, which seems odd that it would be new, is this increased emphasis on reproducibility. And that doesn't just mean statistical reproducibility, but also computational reproducibility and scientific verifiability. And of course, this is becoming really big, and it has to do with what Arvin talked about finding the false positives. It's easy to find false positives. So we have to be very, very vigilant in that, and reproducible research seems to be one of the solutions. I'm going to skip this one because I just want to give a shout out to the Canadian Institute for Statistical Sciences because I'm the director, but also the Mathematical Sciences Institutes who funded much of this work and was so helpful to kind of start to build these bridges that we continue to build with events like this. Thank you.
Thank you, Nancy. That was really terrific. What better name for a journal for statistics than significance? I didn't know that. Pretty impressive. So now we're at the end for general questions. So Arvin, would you like to join us at the front? I know, Steve, I think you need to go out and teach, so thank you very much. So we have about, I believe, just under 15 minutes for questions, so please go ahead and go ahead, please.
The question is for Dr. Reid. Thank you very much for a very professional talk. What I was curious about is that statisticians for a long time have been struggling with our friends in epidemiology who've been misusing p-values and all sorts of methodologies. And for whatever reason, we haven't caught up with what is both the logic and the best practices of current statistical methods. What mistakes do you think that we should not be replicating, and what changes have to happen to our current repertoire of statistical methodologies to accommodate big data? Or do you think there doesn't need to be a change?
Oh, I think there needs to be a change, and I think there needs to be a change with small data too, right? Often epidemiology data sets are not that big. I think that big data is bringing the problems more to the forefront. It used to be that the statisticians would be quiet skeptics, but now with failures that are more public, you start to look at the foundations. there's been a tremendous overemphasis on p-values. I Googled statistics is boring last night, images. That's where I got the students all asleep. But I came across a website called Statistics Isn't Boring. And there's a picture of, say, a African-American gangster rapper. And it says, if your P is too low, then your hoe must go.
Well, I'm glad we're getting very interdisciplinary.
And that kind of thinking, I think statisticians have been somewhat responsible for that. But on the other hand, I think scientists are looking for rules, and that rules-based focus has to go. I think. And I think big data is helping us grapple with that.
Other questions? Go ahead, please.
I'm curious your thoughts on consent as technology is changing. How useful is it now, and what would be
valid? Well, I don't know, because I'm not involved in trials, so I don't really know what all the issues, but they are very complex, and they're, so there's the issue of restricting access of researchers if the patients haven't consented long ago, right? So now we could use this data for all kinds of new things that weren't foreseen when it was collected. But in some cases, if the patients haven't consented to that, you can't use it. And that's an issue I don't understand very well how to come to grips with. There's another aspect that someone pointed out, which was people are pretty willing to consent to having their data used if they see it as a direct benefit either to society or to themselves. But they don't want to have it used for people just to learn about them for no particular reason. So sometimes people with various illnesses are quite willing to upload very personal data and make it public to researchers just to solve the problem. So it has something to do with how you get to control how the data is used. And there's smarter people than me working on it. I mean, it's a really complicated subject, but it's quite important going forward.
Could I ask Arvin and Nancy, that reminds me of what I've heard is data altruism. So there's a whole kind of field where people are talking about people volunteering. Can you comment on that, Arvin?
Yeah, I mean, there's a lot of work being done on implied consent versus explicit consent, and what it means when you give consent for use of your data. It's a very, as Nancy says, a very complicated area, what you're actually consenting to. You know, I said this little thing about looking for a room in Dublin, and suddenly that information was shared very broadly. So if I go onto Google and say, look for a room in Dublin, does that give Google the right to share that information with all sorts of advertisers who want to now market products to you? And I fully expect within a few days we're going to get guided tours in Dublin and, you know, all sorts of other things for Dublin coming at us. So they would argue this is implied consent. The very fact you're using a public database gives the owner of the database the right to share your information. It gets very tricky with medical data, what implied consent you're giving. If you give consent because you think it is a public good, can you put parameters around that public good for how far your data can be used? Which is where this idea that you anonymize data comes from. And you know, I guess I'm on the side of people who think that it's very hard to anonymize data. You know, this idea of just taking off your personal identification information and therefore it's anonymized will not work, because there's only, 6 billion human beings? 7 billion human beings? But the amount of data that we each generate is many, many, many orders of magnitude above that. So even when you give consent, it's not clear what you're giving consent for. I think that we're going to run into all sorts of issues like this with employers now. People have looked into suing someone for not hiring them because they found their information on the internet. Can you use that? Did you give consent? If I have a Facebook page, am I giving consent to anyone to use the information I put there to deduce other things about me. So I think privacy is an absolutely fascinating interplay between technology and social networks and social sciences. So I would agree that that's going to be, maybe even more than the technological side of big data, the implications of what we're giving permission for and how those permissions are given will be just a fascinating field.
See, just to build on that, as we're looking at, we're trying to design some programs in computing for medicine in that area. And so you start with the ISIS database, anonymized. It's mostly administrative data. Then you've got hospital data, and then you've got the data that the individual has on their, as you said, your Fitbit, or lots of people have lots of data, and they don't have the same level of privacy that you'd expect in a hospital. How do they exchange that? So there are some labs you can go to, I know in Alberta, I think in BC as well, there's a personal health record where you can take a lot of your data, put it on your iPhone, then you transport that, and that works around the other barriers that are there. How do you do that? How, as a practitioner, do you work with somebody so that you're protecting their privacy? How are people educated? How do they know? Just your Google example is great. The health app on Apple, if you have your heart rate instead of going in there, who protects that? What right do you have to put barriers around that? How can you transport it? Those are, to me, all really really complex.
I was talking to some young people who wanted to who are creating a company to store all medical data, the individual, on their iPhone. So X-rays, all the diagnostic tests. But it's a real problem. First of all, you may think you own all that data. Do you actually own it? Then what do you do with the data? Because you expect a certain level of security, which probably doesn't exist on these kinds of devices. You expect that, as they thought about how you store the data in a secure way, they just ran into all sorts of problems. And then there's the interface with a provider when you transfer the data to someone else. Is that interface secure? Is the